I'll be presenting on behalf of Medicine 4. The topic is young at heart and brain. So we have this Mr. S. He's a 29-year-old male from Balapet. He presented to casualty with complaints of vomiting since 1 day, fever since 1 day, which was high-grade fever with chills, headache since 1 day, with 2 episodes of seizure since 1 day, associated with altered sensorium. Significant past history was he had a history of RTA in 2012 with history of mild head injury, nasal and oral bleed in January 2012. Following which he had the imaging showed right frontal pneumocephalus, paranasal sinus fractures with no CSF rhinorrhea, and he was managed conservatively at that point. This time when he presented, his examination showed a pulse rate of 120 per minute with a blood pressure of 120 by 80, respiratory was 26 with a GCS of 9 by 15, and he was afebrile on presentation. CNS examination, he was drowsy, disoriented, his memory was impaired, and he appeared very agitated. Fundus examination showed no papilledema. Cranial examination showed dorsal reflex were present, pupils were bilateral, equal and reactive. With no obvious facial deviation, gag reflex was present. Motor power was reduced in bilateral upper limb and lower limb with 3 by 5. Sensations could not be assessed at that point. Reflexes were 1+, and plantars were extensors on the left limb. Significant finding was meningeal signs, a mild terminal neck stiffness was present. Other system examinations were unremarkable. So here we have a gentleman, 29-year-old gentleman with history of acute onset fever, headache, vomiting, seizure, and altered sensorium for 1 day. So the differentials that we considered at that point were obviously the an acute pyogenic meningoencephalitis picture. Second differentials that we considered was a cortical venous thrombosis. Third that we considered was a cerebral abscess. Fourth, because he presented in April, March time, differential of heat stroke was also considered. So investigation showed leukocytosis with neutrophils 91% and 86%, and because there was no papilledema, we went out with the CSF, which showed WBC count of 1100 with a neutrophilic polymorph predominance 98% and lymphocyte 2%. Bacteria were present. Glucose was 64 with elevated proteins 214. CSF Gram-stain showed many pus cells with many GPC pairs, pairs with short chains. So at this point, the most expected organism that we thought of was Streptococcus pneumonia. And imaging was also done. MRI brain was done, but showed a cervical hyperintensity suggestive of meningeal inflammation. There was also another significant finding, which was an incidental recanalized late subacute versus chronic CVT of superior sagittal sinuses. So like I said, the obvious etiology that we considered at that point was a Streptococcus pneumonia, which is one of the most common etiological agent for bacterial meningitis in adults. To our surprise, the CSF-Culture was reported as Streptococcus beta hemolytic group B, that is GPS. So looking this a quick review into what GPS can cause in adults. GPS group, that is group B streptococcal infections. It is a gram-positive cocci. It frequently colonizes the human genital and GIT and upper respiratory tracts in young infants. There are the most important cause of infection. It's an important cause of infection in 3 different populations, especially neonates. It's acquired in, like we said, it frequently colonizes the human genital tract. So it's one of the most common organism etiological agent for neonatal meningitis. So the neonates acquire either in utero or during passage through the vagina. In pregnant women also, it's known to be a frequent cause of UTI, chorioamnionitis, postpartum endometritis, and bacteremia. In non-pregnant adults, it's been increasingly recognized as a cause of bacteremia without a focus, soft tissue infections, other focal infections also. So risk factors for the development of GBS, group B streptococcus infection is there has been isolated case reports showing the following risk factors. Diabetes mellitus is one of the most common risk factors for developing obesity, malignancy, HIV infection, and advanced hepatic and renal diseases, alcoholism, cardiovascular disease, collagen vascular disease, and trauma, and even remote history of trauma has been known to cause group B streptococcus infection. And the risk is markedly increased in older adults, particularly in nursing home residents. So let's look at what the role of GBS in adult meningitis. Although it was considered very rare in the past, GBS meningitis in adults has become very increasingly frequent. It has been increasingly reported over the last few years. It accounts for approximately 1% of all cases of meningitis, and there has been equal incidence noted among immunocompromised and immunocompetent hosts. Different papers shows approximately 20% mortality in GBS meningitis, and if the age is more than 65 years, the case fatality rate can go up to as high as 56%. The incidence of infection has been a bimodal distribution with peaks in the mid-20s and another in the mid-60s. So in our patient, initially thinking it was streptococcus pneumonia, he was initially started on ceftriaxone along with dexamethasone suspect. So after the culture reports, the antibiotics were subsequently changed to crystalline penicillin based on the sensitivity report, and he was discharged in a stable condition. But there were certain questions that were left unanswered. A couple of questions that we wanted to answer. One was the chronic CVT that was noted in MRI with recanalized dural sinuses. The patient, we got a neurology opinion also on the CVT because the patient was asymptomatic for about 6 years. This was just an incidental finding which was related to the previous trauma that he had, and the patient had been asymptomatic, so there was no active intervention required for the chronic CVT that was noted. Second question that we had to answer was, why did this patient get this organism? Then we went back into the history. After digging into the history, we got to realize that the patient had history of recurrent clear watery nasal discharge for the past 1.5 years, associated with history of anosmia. Once we got this history, we got ENT also involved in the same. Rigid nasal endoscopy was done in the ward to rule out CSF rhinorrhea, but rigid nasal endoscopy did not show evidence of CSF rhinorrhea. Later we got a MRI CT for CSF rhinorrhea protocol, which showed a defect in right orbital plate of frontal bone adjacent to the medial orbital wall, and there was evidence of CSF communicating into the ethmoidal sinus on right side, which was extending into the right orbital air cells, which means there was the patient has been having history of recurrent CSF rhinorrhea. So later we admitted the patient under ENT. CSF repair surgery was done, and currently the patient is doing well. So the learning objective from this is we have to keep in mind the increasing prevalence of group B streptococci infections in adults, even though it is still most commonly seen among neonates. Thank you. Studies have shown mortality as high as 27%, and especially if the age is more than 65%, it can go up to more than 50% mortality.
Do we have any local data about its sensitivity pattern in our group B streptococci? Does our antibiotic manual, does it have? Because we have it for strep pneumonia. For GBS, do we have?
Local data, I have not found anything. I'll look it up.
Okay. So they're all penicillin sensitive.
Yes, sir. Penicillin sensitive.
Okay.
So where do you think the group B streptococcus came from?
He had CSF rhinorrhea, sir, and GBS is known to colonize the upper respiratory tract. So CSF rhinorrhea, there was a loss of protective barrier, so that could have predisposed him to meningitis.
So, what are the clinical features of a post-traumatic meningitis? A patient like this who's had a history of trauma, who has a CSF rhinorrhea, how does the clinical presentation differ from other patients who have a pyogenic meningitis? In this patient, what do you notice about the rapidity of the development of the symptoms? He presented within 2 days, right?
One day history.
Yeah, so he had a very rapid course. And if you look at what you notice about the CSF cell counts here, within 1 day,
11,000.
development of the symptoms, he's developed 1,000 cells, and you've got gram-positive. So the rapidity of the presentation is, that's what's striking in this case. And so obviously, in a patient with a pyogenic meningitis, always ask the history of prior trauma, and that was a clue in this case to your diagnosis of pursuing the diagnosis of a CSF rhinorrhea.